Hello, and welcome to Chapter 16 on treatment and therapy. When you hear the word therapy, you might picture someone lying on a couch talking about their childhood or a TikTok video about setting boundaries. You might also have heard people say things like just get over it or medication is just a crutch, usually from the outside of the experience of actually needing help. In this chapter, we're going to zoom in on what treatment really looks like, who gets it, who doesn't, how it's changed over time, and what it means to sit in a room or nowadays on a video call and try to change your mind, your behavior, or your life with another human being. By the end of this chapter, you will be able to describe the main types of therapy and what they aim to change, explain how different treatment settings and modalities work, and summarize how substance use treatment and sociocultural factors fit into the bigger picture. You will be better equipped to recognize what ethical, evidence-based care looks like and to think more critically about the gap between the mental health care people need and the care that they actually receive. When most people think about therapy, they imagine someone sitting in an office talking about their feelings. That is one version of treatment, but it's only one. Programs like the surf-based ocean therapy for veterans show that treatment can also look like being out in the ocean, learning a new skill, and talking with peers who actually get what you've been going through. The important thing isn't the surfboard, it's the combination of support, structure, and processing wrapped into something people are more willing to engage with. So when we say therapy and treatment in this chapter, we're talking about a wide range of ways people get help with psychological distress. So talking therapy, skill-based work, group and community approaches, and medical interventions like medication or hospitalization. As you're listening, keep in mind that therapy isn't just one size fits all. What works for a Marine with combat trauma might look very different from what works for a teenager with social anxiety or even from an adult living with bipolar disorder. Mental health concerns are really common. Every year, roughly 1 in 5 adults and a significant portion of children and adolescents experience a diagnosable mental illness. That means if you think about your family, your friend group, your class, your coworkers, someone in those circles is dealing with anxiety, depression, trauma, or something similar right now in this moment. This isn't a rate other people issue, this is part of the landscape of human life. Even with those numbers, only a small portion of people who meet criteria for a disorder actually receive treatment. Some never get screened, some don't recognize their experiences as treatable, and others run into barriers that we'll talk about later, like money, access, stigma, and culture. A helpful mindset is this: mental illness is common, effective treatments exist, and a big part of the challenge is who we can actually get into those treatments. This graph is basically showing the gap between the need and care. You see bars creeping up a little bit over time, more adults receiving some kind of mental health treatment, but the increase is modest compared to how many people are struggling. If you go back far enough, mental illness was often explained in supernatural terms: demonic possession, curses, and witchcraft. If you believe the problem is a demon, then the treatment becomes exorcism, prayer, or punishment. Practices like trephining, drilling holes into the skull, were sometimes used with the idea of letting spirits out. In many cases, people were imprisoned, tortured, or executed, especially women accused of being witches. It's easy to look at that and think, well, people were just cruel. But remember that they were operating from the explanations that they had at the time. When the model is evil or sin, the response is to control, punish, or expel. A big thread in the history of treatment is, as explanations become more medical and psychological, treatments gradually shift from punishment toward care and rehabilitation. By the 1700s, large asylums were being created to house people with mental illness. The theory was this: separate them from the rest of society and keep everyone else safe. In practice, many of these institutions were overcrowded, filthy, and focused more on containment than any kind of actual therapeutic work. People might be chained to walls, kept in windowless rooms, and given minimal food and human contact. The Goya painting often shows for this period. The madhouse isn't just art, it captures the chaos, fear, and dehumanization that many patients lived in. It's a reminder that institutional care does not automatically mean treatment. It matters how people are treated inside of those walls, and whether they're seen as human beings in distress or problems that need to be locked away or hidden. Pinel is one of the first names associated with the real shift in attitude. In late 18th century Paris, he argued that people in asylums should be unchained, allowed outside, and spoken to with respect. The famous image of him ordering the removal of chains at the hospital symbolizes that shift toward what was called moral treatment. Not moral in the sense of judging patients, but in the sense of humane, dignified care. When staff started treating patients as people who could improve, not as animals to be restrained, many people actually did improve enough to be discharged. That doesn't mean everything was suddenly ethical and evidence-based, but it does mark an important pivot from warehousing and punishment toward the idea that people with serious mental illness can recover or at least stabilize with the right kinds of support. If you had to sum up Pennell's contribution in one sentence, how would you describe what and how things changed? In the 1800s, Dorothea Dix played a similar role in the United States. She visited jails, almshouses, and other institutions and found people with severe mental illness chained in basements, living in filth, or housed alongside violent offenders with no treatment. She documented what she saw and took those reports to lawmakers, arguing that this was unethical and unacceptable. Her advocacy led to the establishment of state-funded mental hospitals across the country. The idea was to create more humane settings with some level of structure and care. Again, these are not perfect places, and they weren't perfect places then, and many became overcrowded themselves, but they represented the attempt to move people with mental illness out of jails and poorhouses and into facilities that, at least in theory, were designed for their needs. Over time, the good intentions behind many state hospitals ran into the realities of limited funding, rising admissions, and not enough staff. Asylums became overcrowded and understaffed, and actual treatment often gave way to basic custodial care, keeping people fed and housed, but not making much effort to help them improve. Conditions could become harsh again: long-term restraint, forced baths, early versions of ECT, and a little meaningful engagement. For many patients, entering an asylum meant staying there for decades or for their lives. Families sometimes dropped people off and never came back for them. This history matters because it influences how people feel about hospitalization today. There's still cultural memory and fear around the idea of being locked up or sent away, even though modern inpatient care looks very, very different than it used to. The mid-1900s brought a huge shift with the development of antipsychotic medications. For the first time, there were drugs and medications that could significantly reduce hallucinations and delusions for many people living with schizophrenia and related disorders. That opened the door to the idea that long-term hospitalization might not be necessary for everyone. Around the same time, U.S. policy shifted towards building community mental health centers, with the goal of treating people closer to home. This led to deinstitutionalization, the large-scale closing or downsizing of state hospitals. On paper, the plan was this: to move people out of big institutions and into community-based services. In practice, many community centers were underfunded and understaffed. A lot of people were discharged from hospitals but didn't get the outpatient support that they needed to stay stable. That gap is one of the reasons we see so much mental illness intersecting with homelessness and the justice system today. Now, today, a disproportionate number of people with serious mental illness are found in homeless shelters and in jails and prisons. Some end up homeless because symptoms make it hard to hold jobs or maintain housing. Others are arrested for behaviors that stem from untreated illness, public disturbance, minor theft, substance use, or simply not following directions in a tense encounter. In many communities, jails have become the de facto psychiatric facilities, even though they are not designed to be anywhere near that role. This creates a loop. People cycle between the street, emergency rooms, brief hospitalizations, and jail without sustained access to treatment, housing, or support. So when we talk about mental health treatment today, it's important to include these realities, not just the ideal of therapy offices and clinics, but the systems that people actually have to move through in order to obtain services. Right now, most formal mental health treatment happens in short-term settings. Hospital stays are usually really brief. often a few days to a couple of weeks, and are focused more on stabilizing someone who is in immediate crisis or risk of harm to self or others. Once the immediate crisis is managed, people are discharged with referrals to outpatient care. Insurance and cost play a huge role in how long someone can stay and what services that they can access. Outside of the hospital, treatment happens in community mental health centers, private practices, school counseling offices, college counseling centers, integrated primary care clinics, and group settings. Providers can include psychiatrists, psychologists, licensed professional counselors, clinical social workers, marriage and family therapists, psychiatric nurse practitioners, and many others depending on the state. Some people go voluntarily, and others may have to be court ordered or brought in under involuntary commitment laws for their own safety. As you think about this, it can help to ask, if I or someone I cared about needed help, where in this system would we realistically end up? Here you're seeing the menu of treatment options all in one place. We've got psychological therapies like talk therapy and skills-based work, biomedical approaches like medication and brain-based treatments, and different settings such as inpatient, outpatient, and community-based programs. It's a reminder that when someone is struggling, help might look like weekly counseling, a brief hospital stay, medication management, a support group, or a mix of some of those pieces over time. Rather than thinking which one is best, it's more useful to think which combination fits with this person and with their needs and resources right now in this moment. Treatment isn't one size fits all. A teenager with a panic attack or panic disorder might be in cognitive behavioral therapy and seeing a prescriber. A veteran with PTSD might do some group work plus medication through the VA. A child with autism might get behavioral support at school and parent training at home. This chart is just a starting map, and these are the main lanes treatment tends to run in, and most real-world care blends into more than one. Psychoanalysis is where formal psychotherapy really started, with Freud. The basic idea is that the current problems are rooted in unconscious conflicts and in early childhood experiences. In classic psychoanalysis, the therapist helps to bring these hidden conflicts into awareness so the person can work through them instead of repeating the same patterns over and over. Techniques include free association, which is saying whatever comes to mind and noticing what gets avoided, dream analysis, and paying attention to slips, jokes, and themes that keep popping up. Another big piece is transference, the way the client starts to relate to the therapist as if they were a parent, partner, or another important figure. Those patterns can reveal how the client expects relationships to go, being abandoned, criticized, controlled, or rescued. Modern psychodynamic therapy keeps the focus on unconscious patterns and relationships, but is usually shorter, more focused, and much more conversational than the stereotype of years on the couch. This is the classic image most people have when they think of therapy. A couch, the client lying down, the analyst sitting just out of sight with a notepad and asking, okay, and how does that make you feel? In that setup, that idea was not seeing the analyst's face would make it easier for the client to say things that they might otherwise censor. The room, the objects, even where people sat were all part of the technique. It's worth mentioning that most therapy today doesn't look like this. You're much more likely to be sitting face to face on a regular chair or couch, sometimes even in a Zoom call in your own hoodie or in your room. But this image still matters because it does shape the cultural picture of what therapy was, and for some people, that picture is either really intimidating or sometimes somewhat comforting. Play therapy adapts those deeper, insight-focused ideas for children who don't usually sit and talk about their feelings in paragraphs. Instead, they show what's going on through play. Play is child's language. In the playroom, the toys are the words. Kids might act out family scenes with dolls, repeat themes with animals or superheroes, or use sand tray figures to build out a world that says a lot about their inner world and what feels safe and what feels scary. There are non-directive approaches where the child leads and the therapist follows and reflects, trusting that what needs to surface will show up in the play. There are also directive approaches where the therapist introduces themes, prompts, or specific activities to help a kiddo or a child work through trauma, divorce, grief, or other behavioral issues. Either way, the goal is the same as adult therapy. Give the person, the child, a safe space to express and organize what they're carrying, just in a language that fits their developmental level. So if you were to think back to how you played as a kid, Do you remember any themes that you repeated a lot? Rescue, conflict, organizing things, or building safety zones? Behavior therapy starts from a simpler question. What is the person doing, and how can we help them to do something different? Instead of digging into childhood, behavior therapists look at learned patterns, especially around fear and avoidance, and use learning principles to shift them. With classical conditioning based methods, the focus is on changing the link between a stimulus and an automatic response. Counter-conditioning pairs the thing that triggers fear, like dogs, heights, or crowds, with new incompatible responses such as relaxation or positive experiences. Aversive conditioning does the opposite. It pairs an unwanted behavior, like drinking, with something unpleasant, such as a medication that causes nausea when alcohol is consumed. Exposure therapy repeatedly brings someone into contact with the feared situation in a safe and controlled way, so their nervous system relearns this is uncomfortable, but it's not actually dangerous. We can do this. Mary Cover Jones is often called the mother of behavior therapy. She worked with a little boy named Peter who had a strong fear for rabbits. Instead of lecturing him on how rabbits are harmless, she paired the rabbit's presence with something Peter liked, such as a snack, and started at a distance that didn't overwhelm him. Over sessions, she gradually moved the rabbit closer while keeping him calm and comfortable. Eventually, Peter could sit near the rabbit and even touch it without panicking. That's exposure and counter-conditioning. The fearful stimulus, the rabbit, no longer predicted terror. It started to show up in a context of safety and pleasure. That same basic idea underlines a lot of the work with phobias and anxiety. Start where the person can tolerate, pair it with a sense of safety, and move forward slowly and appropriately. Joseph Wolpe took those ideas and turned them into a structured method called systematic desensitization. First, the person learns a reliable relaxation technique, often progressive muscle relaxation. Then they work with the therapist to build an anxiety hierarchy, ranking situations from least to most scary. Once that's set, then they start at the low end and imagine or later actually face those situations while staying relaxed, moving up only when each level or each step feels manageable. The idea is that your body can't be deeply relaxed and highly anxious at exactly the same time. And over time, the anxious response gets weaker and the calmer response gets stronger. Modern versions sometimes use virtual reality to approximate flying, combat, heights, or other situations that are hard to recreate in real life. But the underlying principle is the same as Peter and the rabbit: gentle, repeated, supported exposure. This is really putting exposure therapy into context. So for somebody with arachnophobia or a fear of spiders, looking at a spider across the room can be a really big deal. In a well-done exposure session, the therapist isn't showing a tarantula to them. They're starting where the person can tolerate it. Maybe it's photos first, and then a spider in a closed container across the room, and gradually moving closer. The important piece is that the person chooses to stay with the discomfort long enough to learn that nothing catastrophic is going to happen. Over time, their fear curve tends to spike and come right back down instead of staying sky high. This is the opposite of what happens when we avoid something forever. The avoidance gives quick relief, but the fear never gets a chance to update. On the operant conditioning side of things, behavior therapy looks at what happens after a behavior, what gets rewarded, what gets ignored, and what gets punished. Applied behavior analysis uses this approach a lot, especially with children on the autism spectrum. Desired behaviors like making eye contact, using words instead of hitting, or following directions are followed by reinforcers that actually matter to the child: praise, tokens, time with a preferred toy. Undesired behaviors might lead to a loss of a privilege or a brief timeout. In token economies, people earn points, chips, or tokens for specific behaviors, like taking meds, attending group, completing chores, and later exchange them for privileges or items. These systems are common in psychiatric hospitals and in some correctional facilities. They're not magic, and there are real debates about how to do them ethically, but they are built on the simple idea that behavior is constantly leading to something rewarding is more likely to stick. Cognitive therapy was developed by Aaron Beck, and it starts from the observation that it's not just what happens to us that matters, but how we interpret it. Two people can experience the same event, a breakup, a low exam grade, or a friend not texting them back, and walk away with very different internal stories. One might think, this hurts, but I'll be okay, while another thinks, this proves that I'm a failure and everyone leaves me. The second story is going to feel a lot more heavy. Beck talked about cognitive distortions, habitual ways of thinking that are skewed and unhelpful. Examples include overgeneralization, so I messed up once, I'll always mess up. Black and white thinking, which is all or nothing. If it's not perfect, it's a disaster. And mind reading. They didn't say hi to me, they must hate me or be mad at me. In cognitive therapy, the work is to notice the patterns, question them, and test out more balanced alternatives. The goal isn't forced positivity, it's accuracy and flexibility in thinking. And this is the visual reminder that if you constantly filter experiences through themes of loss, defeat, and worthlessness, your mood is going to follow. If every neutral event becomes proof that you're failing or unlovable, it's very hard to climb out of a depression. One helpful question here could be this: what else could this mean? If a friend cancels plans, it could mean that they secretly hate you. But it could also mean that they're exhausted, double booked, or dealing with something that you don't know about in this moment. Practicing that kind of cognitive flexibility is a huge part of how cognitive therapy helps to shift mood and behavior over time. Now, cognitive behavioral therapy combines all of this into very practical framework. Change your thoughts and change your behaviors, and your emotions will usually shift as well. It's typically structured and time limited. Think homework, worksheets, tracking thoughts, and practicing new skills. The focus is on what's happening now rather than doing a deep dive into every childhood experience. The ABC model is one way to map it out. A is the activating event, so it's the thing that happened. B is the belief about it, so the thought that you had in response to the activating event or the thing that happened. And C is the consequences, so how you felt and what you did in response to the belief and the situation. CBT helps you to zoom in on the B and experiment with new responses while also changing the consequences or how you felt or did by doing different behaviors, like approaching instead of avoiding or scheduling pleasant activities to combat withdrawal. A lot of modern evidence-based protocols for depression, anxiety, and PTSD grow out of CBT ideas, even if they use different names now. Humanistic therapy shifts the emphasis to growth, authenticity, and the person's own sense of direction. In client-centered therapy, Carl Rogers argued that people are naturally oriented towards growth if they're in a relationship that provides genuineness, empathy, and unconditional positive regard. The therapist isn't there to analyze or advise so much as to create a space where the client feels deeply heard and accepted. This approach is non-directive. You, as the client, decide what to talk about, and the therapist reflects, clarifies, and helps you to hear yourself. Over time, that can loosen up rigid self-judgments and make it easier to make choices that fit with who you actually are. Even if the therapy primarily uses cognitive behavioral therapy or a different model, many incorporate humanistic elements because feeling safe and respected is important to make any technique work. And side note, it doesn't really always matter the modality that is used in therapy. The relationship that you have with a therapist supersedes almost all of that. Just, something to know. If you were in therapy, which would you feel more helpful? What would feel more helpful to you right now? Someone challenging your thought patterns and your behaviors, or someone sitting with you in empathy and helping you to hear yourself more clearly? Biomedical therapies focus on changing the brain directly. The most common tools are psychotropic medications, antipsychotics, both older and atypical newer ones, target dopamine and sometimes serotonin systems to reduce hallucinations and delusions. Antidepressants affect serotonin and or norepinephrine levels to help with depression and many anxiety disorders. Anti-anxiety medications dampen overactivation in the nervous system, and mood stabilizers are used in bipolar disorder. Stimulants can help improve ADHD and impulse controls as well. There are also non-medication biological treatments. There's electroconvulsive therapy, or ECT, which has a rough history and is now carefully controlled and can be very, very effective for some with severe treatment-resistant depression. Transcranial magnetic stimulation, or TMS, uses magnetic fields over specific brain areas and is another option for depression that hasn't responded well to medications. None of these treatments change the circumstances of one's life, but they can shift the biological part of the equation enough that therapy, relationships, routines, and coping can start to take root. So, before any real therapy work gets started, there's usually an intake process. This is the first meeting where the therapist is trying to understand what brought the person in, what their life looks like, and what kind of help they're looking for. They will ask the client, or the therapist will ask about current symptoms, major stressors, medical history, substance use, safety concerns, and what has or hasn't helped out in the past. It can feel a little like an interview, but the goal is to get enough of the picture to make good decisions, not to interrogate the person about their life. Intake is also where you go over confidentiality. What stays in the room, and what the legal limits are. They usually will talk about fees, scheduling, and any basic expectations. From there, the therapist and client will usually come up with something called a treatment plan, which is a shared sense of what you're working on and how you'll know if things are getting better. That might be written out formally for insurance, but underneath it's just a simple question of what are you trying to change and how are we going to get you there? Individual therapy is what most people picture first. It's client, a therapist, usually for about 45 to 50 minutes. That time can be used to process emotions, unpack patterns, learn skills, or problem solve around specific situations. Some sessions are structured with homework and worksheets, while others are more open with the therapist helping the client follow what feels important for that day. The consistency, the same person, regular time, same basic frame, creates a space where people can say things that they don't say anywhere else. Group therapy shifts that dynamic, and instead of just you and a therapist, you're in a small group of other people dealing with similar issues. Grief, substance use, depression, trauma, and relationship patterns are pretty common groups. Groups can be really scary to walk into, but they're really powerful for reducing shame because it helps you to think that I'm not the only one, and for seeing yourself in other people's stories. There are also psychoeducational groups that mix teachings with discussion. Things like parenting groups, cancer support groups, or dialectical behavior therapy skills groups. The trade-off is that you have less privacy, but the benefit of added connection and feedback that you don't get in one-to-one therapy. If you had to choose today, which would you be more likely to try? Individual therapy or group therapy with people who get what you're going through? Couples therapy focuses on the relationship as the client. The work usually centers on communication patterns, conflict cycles, and emotional connection. Instead of deciding who is right and who is wrong, the therapist helps the couple slow down arguments, actually hear each other, and experiment with new ways of responding. That might mean practicing how to bring up a hard topic without attacking the other person, how to listen without defensiveness, or how to rebuild trust after something painful happens. And family therapy takes a systems view. Each person's behavior is connected to everybody else's. A teenager's outburst, for example, might be tied to parental conflict, unclear rules, or sibling dynamics. Structural approaches look at boundaries and roles, who's in charge, who's taking care of who, and while strategic approaches target specific patterns that keep problems in place, the goal isn't to fix one identified person, but to help the family shift into patterns that work better for everyone involved. Addiction usually starts out in a very ordinary, normal way. Someone uses a substance to relax, fit in, numb out, or have fun. Over time, with repeated use, those substances start to change the brain, especially areas like the prefrontal cortex that handle judgment, planning, and self-control. What began as a choice can shift into a pattern where the person feels driven to keep going, even when they genuinely want to stop, and can see the damage that it's causing. That's a big part of why addiction is understood as a chronic brain disorder, not just a series of bad or poor decisions. Relapse is also really common, often quoted around 40 to 60%, and it's not a sign that someone didn't want it enough. It's more like other chronic conditions like diabetes or hypertension, where symptoms improve, flare up, and need to be managed over time. Addiction often shows up along other mental health issues. People with anxiety, depression, PTSD, or other disorders might use substances to cope and reduce their symptoms, and heavy substance use can worsen or even trigger mental health symptoms in return. That combination, sometimes called dual diagnosis or mentally ill and chemically addicted or MICA, can be especially hard to treat if systems only focus on one side of the problem at a time. The survey data breaks things down by age group here, usually 12 to 17, 18 to 25, and 26 up, and by different substances. You typically see the highest rates of use in the 18 to 25 group and lower rates in younger teens and older adults. That doesn't mean that they don't struggle with addiction, it just means the patterns look different and sometimes are less visible. Treatment for substance use isn't just about getting someone through detox, although that is an important first step when withdrawal can be really, really dangerous. Medicine can reduce withdrawal symptoms, prevent seizures, and sometimes block or blunt the effects of certain drugs. But once the immediate crisis is past, the work shifts to behavioral and psychological change, learning new coping skills, managing cravings, handling triggers, and rebuilding routines and relationships. Good substance use treatment is usually long term. It might include individual therapy, group work, support groups like NA, AA, or Smart Recovery, family involvement, and sometimes medications that help maintain sobriety. For example, medications that would reduce alcohol cravings or stabilize opioid use. It's also most effective when it looks beyond just stop using and addresses the rest of the person's life, like housing, employment, legal issues, medical care, and mental health. So, what makes treatment effective? One key factor is time. Programs that keep people engaged for at least 3 months tend to have better outcomes than very short stays. That doesn't mean everyone needs the same level of care for the same length of time, but it does mean quick fixes don't usually stick. Effective treatment also needs to be holistic. It looks at stress, relationships, parenting, work, school, legal problems, and physical health, not just the substance use itself. Group therapy and peer support play a huge role, especially for maintaining change for the long haul. People often say it helps to sit with others who really understand cravings, relapse, and shame from the inside. For teens, parental or caregiver involvement can make a really big difference here too. So, setting boundaries, learning new ways to respond, and supporting healthier choices. Through this lens, brain changes, environment, mental health, and relationships, how does that shift the way that you think about willpower and choice for a person in recovery? Instead of looking only at symptoms inside of a person, the social cultural model asks what's going on around the person. What is their cultural background, their community, their family experiences and expectations, their experiences with racism, poverty, or discrimination? All of that is really important in how it shapes how distress shows up and how comfortable someone feels seeking help. Your own beliefs, values, and identities affect how you feel about therapy and medication. For example, some cultures see going outside the family for help as disloyal, and others view mental health treatment as normal as going to the doctor. Cultural competence means mental health professionals do the work to understand and honor these differences, not treat everyone as if they grew up with the same norms. Multicultural counseling tries to align goals, strategies, and language with a client's real life, balancing individual needs with the importance of family, community, and culture. Even when good treatment exists, a lot of people never make it through the door. Some barriers are practical, such as no insurance, high deductibles, no time to take off work, not able to take off work, no transportation, or no providers nearby who are taking on new clients. Others are structural and ethical, like the lack of bilingual or culturally responsive services in many areas. So even when access looks equal on paper, marginalized groups often use services less than white middle class Americans because the system wasn't built with them in mind. There are also attitudinal barriers, stigma, fear of being misunderstood. We don't talk about that outside the family, or the belief that you should handle things on your own. Some people don't see therapy as effective, others worry about confidentiality or fear of being hospitalized if they're too honest with their therapists. All of these factors add up to a lot of silent suffering as you think about any of the future roles that you might have in psychology, healthcare, education, or just as a human in a community with other humans. Part of the work is lowering those barriers where you can and being a safer person to talk to, not another reason somebody stays quiet. Therapy and treatment are really about what happens in real time between people. Someone showing up with panic, grief, numbness, or chaos, and someone else bringing skills, structure, and care. In this chapter, we looked at the many ways that can happen: insight-focused work, behavior and cognitive approaches, humanistic therapy, play therapy, medications, and community programs. Underneath all of those models and settings, the basic goal stays the same: help people suffer less and live more of the life they actually want to live. As you step away from this chapter, pay attention to how therapy, medication, and addiction are talked about in your worlds. Who gets encouraged to reach out, who gets dismissed, and who isn't even part of the conversation. When someone mentions being in counseling, taking medication, or working on sobriety, see if you can meet that person with curiosity and respect instead of quick judgment. You're only ever seeing a small slice and a small piece of their story. Understanding therapy and treatment isn't about turning you into a therapist. It's about having clearer language, more realistic expectations, and a little more compassion for all of the different ways people work at getting their feet back underneath of them and live the life that's worth living for them.